Bruce Patterson. He's the founder and CEO of In-Cell Diagnostics. He received his undergraduate training in molecular biology from the University of Michigan in Ann Arbor, and he went on to get his medical degree at Northwestern University Medical School. He was trained as a pathologist and has concentrated a great deal of his work on HIV. During the early stages of the AIDS epidemic, Dr. Patterson began investigating cellular reservoirs of HIV-1 using molecular and in situ technologies patented in his labs. And while in his residency, Dr. Patterson determined that enough HIV virus was present in infected individuals to account for the massive destruction of the immune system. This paradigm-altering work was published in Science in 1993. Dr. Patterson has authored over 100 manuscripts and book chapters, and he continues his work in HIV pathogenesis and reservoirs at Stanford University School of Medicine. Dr. Patterson was the medical director of diagnostic virology at Stanford University Hospitals and Clinic. More recently, Dr. Patterson has been working on finding solutions for post-COVID syndrome, and he's been doing some truly fascinating work on cytokines, which we've had the privilege of being able to participate with him with. My pleasure to introduce Dr. Patterson and turn the podium over to him. You're on.
Thank you, Dr. Kaplan. It's truly been a pleasure not only participating in this meeting, but interacting with you and Dr. Belanti and others previous to this. What I am going to talk about today is the data that we've obtained in over 17,000 patients who have enrolled in our program for treatment, first of long COVID. But as we went along gathering data for the last year and a half, we've also been able to determine there's a significant overlap with conditions such as ME/CFS, post-Lyme disease, fibromyalgia, and also post-vaccination long haulers syndrome, which we're about to submit a paper on. So I'm excited to show you our findings and how we can approach therapy using precision diagnostics and precision medicine to predetermine the potential efficacy of therapeutics. As I mentioned, PASC or long COVID may affect up to 30% of all individuals. And in fact, there's a significant overlap with ME/CFS, which affects somewhere between 1 and 3 million patients. However, I'm going to show you some factors that may be contributing to an emergence or a surge in the number of ME/CFS cases that we see. We think long COVID is a healthcare and economic emergency. There was recent papers on the fact that it represents a healthcare emergency, and because of the effects on the workforce, obviously, if it's affecting 30% of people who get infected. So again, I'll get right into the science of it. As I mentioned, this is the number of potential cases of long COVID and exacerbations or emergences of ME/CFS. And I bring this to bear today because I think there's recent reports of being able to predict who's going to get long COVID. And in fact, one of the parameters of the 4 parameters that were published was Epstein-Barr virus presence. And I would submit that that prediction fell into what you see here in the second category, which is considered to be the exacerbation of ME/CFS rather than true long COVID. It also bears the question that long COVID is a very heterogeneous disease, and of course comorbidities, prior medical history play into that to a great extent in the patients that we've looked at. And I'm going to show you some treatment data and outcome data from our therapeutic regimen when we really isolate who has pure long COVID, devoid of other overlap syndromes. As you can see in this slide, there was some important pathophysiologic findings that we published in our first paper on acute COVID. Most importantly, in the middle, you'll see percent CD8 count. And the percent CD8 was extremely low in some of the severe to critical cases of acute COVID. And I think that's something to really think about, because in terms of predicting who's going to become low COVID, in the presence of very low CD8 and potentially significant impairment in cell-mediated immunity, I think we're seeing the emergence of a lot of the herpes family viruses, the viruses that have been associated with chronic fatigue. So I think that's something to really take account when you're looking at predictive modeling of what acute infected individuals and who's going to become truly long COVID. Let me see, next slide. So, and again, part and parcel to that was a paper that we published last year when we saw actual SARS-CoV-2 viral shedding for more than 87 days in individuals with impaired CD8 T cell responses. And so, you know, we agree that there's a potential for SARS-CoV-2 replication probably out to 3 months. I think 3 months is a great cutoff for long COVID. As I'll talk about in a moment, a paper we published in Frontiers in Immunology earlier this month showed that there was persistence of the SARS-CoV-2 S1 protein in the absence of intact RNA. We found by whole genome sequencing fragments of RNA, but certainly nothing that could lead to intact virions or spread of a viral infection. But what's important about this paper was the fact that the CD8 impairment and the low CD8 percentages was something that persisted for a long period of time. And in fact, in our first cohort of long COVID patients in, I can't believe it, but the fall of 2020, we saw about 25% of long COVID individuals with low CD8 percentages. So it's no surprise to me that you're seeing reactivation of EBV, CMV, HHV6, HSV, varicella, et cetera, the other chronic herpes viral family pathogens. And that gets us to symptoms. The other part of this is when you're calling somebody long COVID, what you're faced with is an overlap, significant overlap of symptoms amongst long haulers, ME/CFS, post-Lyme, fibromyalgia. Here's a figure that was published in our first paper in Frontiers in Immunology last spring. And you can see in the red figures, there's significant symptoms that cross over from ME/CFS. And so, you know, parsing through all the data to understand the differences and the similarities between these two groups is absolute paramount for understanding of these individual entities, but also in terms of therapeutics and where we may be able to find common ground in terms of how we treat these individuals. To further that point, this is a new study that we'll be submitting very, very soon on post-vaccination individuals with long COVID symptoms. Again, using the definition of 3 months following the latest vaccination, whether it's a single shot or multiple shots. This graph shows unequivocally the similarities with COVID long haulers. All these individuals in this study were confirmed not to have had COVID, And in fact, it's an unfortunate experiment that supports our hypothesis that COVID long haulers is driven by the S1 protein, because here's an instance where there was no active virus, there was no virus, but they were basically injected with the S1 protein, and yet months later came up with almost identical symptoms to COVID long haulers. And as I'll mention a little bit later on, we treat them in the same way. Now, this is a very small graph. The only point to illustrate is that we started looking at about 150 biomarkers in acute COVID, every cytokine that you could possibly imagine, chemokines, other biomarkers. And what we did is we took a cohort of patients with symptoms greater than 90 days, and this was in the summer of 2020 when nobody was talking about long COVID, and we put it into a machine learning algorithm and said, you know, what biomarkers are important in defining the difference between acute COVID and long COVID. And, you know, much to our surprise, but I think of some relief to the patients at the time, was that long COVID was real. And I think we've been saying that message for over a year and a half now. I think people are finally getting that this is a distinct immunologic entity. It is very, very real. Patients are horribly debilitated. This needs to be supported by benefits by the government and payers to support both disability and treatments for long COVID. So what we came up with after looking at all these different biomarkers was an assay that consisted of 14 markers, which interestingly really spanned all the different arms of the immune system. And so it was a great representation of what was going on at different stages in acute COVID, developing eventually a severity score for acute COVID with different algorithms, and of course coming up with a signature of cytokine and chemokine expression that defined long haulers that we could follow. This approach has also been instrumental in helping define the differences and similarities between long COVID and ME/CFS, post-Lyme, fibromyalgia, and now post-vaccination long haulers. And what was very interesting in terms of validating this panel, both scientifically and also clinically, as I'll show in a moment, is I'm showing in red boxes this clustering of cytokines that are biologically relevant. We did this was a collection of all of our patients, whether it be long hauler, COVID long haulers, post-Lyme, ME/CFS, fibromyalgia, and post-vaccination long haulers. And we see biologically relevant clustering of these cytokines. For instance, interleukin 13 and interleukin 4 up in the upper left-hand corner are clustered significantly. And of course, they act together as part of the type 2 inflammatory response. So again, reassuring that the panel we chose not only was behaving the way it should be behaving, performing the way it should be performing, but also giving us biologically relevant information, as I'll show when we get onto the correlations with clinical symptomatology. The other association that you see here in the lower red box is an association between interferon and IL-10, which we find that the suppression of the pro-inflammatory macrophages in, for instance, TB, is driven by interferon gamma induction of IL-10. So it makes sense that that those cytokines appear together in a cluster in this particular figure. So what we came up with in terms of having the two algorithms, machine learning and AI, was that we could categorize these four different conditions, COVID long haulers, ME/CFS, post-vaccination long haulers, and we're just getting around to fibromyalgia. But the yellow dots represent the COVID long haulers. The red dots represent the post-vaccination long haulers, and the blue dots are the ME/CFS patients. Again, using the two formulas that make up our long hauler score, which is interferon gamma plus IL-2 divided by CCL4, and our severity index, which you see on the y-axis, IL-6 plus soluble CD40 ligand divided by VEGF and IL-2 plus IL-8, which will come into play later. But I think you can see that not only are there similarities, but there's also subtle differences in these four conditions that we can exploit in terms of therapeutics. Next figure. We're just starting out in defining more appropriately post-Lyme to add to our armamentarium of algorithms. And so far, post-Lyme is looking somewhere between acute COVID and long haulers immunologically. But of course, I think we only had 20 patients in this figure and are looking to add to that cohort. I think what is especially intuitive is when we use machine learning in a confusion matrix, which is basically the relationship between mild acute COVID, severe acute COVID, long COVID, post-vaccination long COVID, ME/CFS, and Lyme. We see that, as you can, in the middle in the white square, that we're extremely accurate in calling COVID long haulers with these algorithms. And, to most part, we're accurate with mild to moderate, severe, post-vaccination, and ME/CFS. Where there is some confusion in terms of the biomarkers is between Lyme and post-vaccination long haulers. And you can see there on that lower row that some of the post-vaccination patients were called Lyme, some of the Lyme patients were called post-vax patients. And the one thing that's common between those two entities that you don't see a lot in the other entities is interleukin-8. And so interleukin-8 is something that we use to decipher whether or not someone is Lyme or post-vax as opposed to a true COVID long hauler. Next slide. So we found an interesting paper discussed amongst our group, and this was a paper from last summer on a cytokine nodal classification of autoimmune diseases. Well, why do I put that up? Well, again, what we've been trying to do in the previous slides is to come up with a classification scheme between these entities that have very similar clinical symptoms. What was interesting about the differences between this paper and what we'll submit shortly in our paper is that these were diseases, autoimmune diseases like rheumatoid arthritis, celiac disease, ulcerative colitis. And these were autoimmune diseases that were classified either by organ or in different cytokine-based concepts. And the big difference between these entities is they have extremely different symptoms, which is different than what we're faced with in terms of conditions that have almost identical symptoms: COVID long haulers, ME/CFS, fibromyalgia, and post-vaccination long haulers, and Lyme, post-Lyme. So we wanted to come up with a scheme similar to this cytokine nodal classification, and that's exactly what we did, and we've been working on for the better part of a month. And I know this is extremely small, but I think we finally nailed it in the last week or so, where we were actually able to find a classification scheme by cytokine nodes, which you see in white kind of along the top descending row, which is a variety of different cytokines. The top cytokine is GM-CSF, followed by, I believe it's interleukin 2 and interleukin 10, and eventually interleukin 8. But we were able to categorize using our panel with great certainty true ME/CFS, which you see in purple, COVID long haulers, which you see in green, post-vaccination long haulers, which you see in blue, and then towards the lower end of this this tree, you'll see post-Lyme and acute and mild to moderate active COVID. And so, you know, we've come up with this classification scheme. Lyme seems to be the most heterogeneous of the group, and it may be because we're just seeing these patients at different points in time relative to when they were infected by one of the organisms associated with Lyme. But I'm very excited about this classification scheme because I think it will really help when people talk about COVID long haulers, because I think when the world is talking about COVID long haulers, you have COVID infection and then you have these symptoms. And I think what happens is we're quick to call them COVID long haulers, when, like I showed, with low CD8 counts, it could be reactivation of chronic herpes family viruses that just reflect the fact that they have ME/CFS or one of these other overlap syndromes. So I think we're getting close to the point where we can actually say who's truly a COVID long hauler, who's truly ME/CFS, who's truly post-vaccination long haulers. Because when they present to us, as you can imagine, with 17,000 patients, we get everything under the sun. And they immediately jump to saying, well, we're COVID long haulers, which they are, you know, incredibly debilitated. And then what we have to do is take into account some of the other comorbidities or cofactors in what they're experiencing, whether it's, you know, well, I also have, I tested positive for EBV reactivation, or, I did have Lyme, 8 years ago, or, these are some of the things that we hear, and thankfully now we can say, you know what, we know exactly what you're going through, and we know how we can parse through all these different things going on in your body that have led to these symptoms. And I think that is what's most refreshing about having this abundance of data to be able to do these types of analyses. I won't go into the individual nodes. Again, we're going to have to figure out a way to actually publish this because it's so small. But again, I'll be providing this, and people can look at what the individual nodes represent that result in this very nice representation based on nodal classification. But what I really want to get to is now what? Treatment. There's been a lot of discussion about this. There's lots of long COVID centers, around the country, and we've been doing it now for over a year and a half. And like I said, I think we have the largest cohort in the world. We've now expanded into the EU and into the UK with our program, and eventually we'll get into Latin America and Mexico, which we're very excited about. But one of the important things is, what have we learned about targeting particular cytokine profiles that come out of our testing? And I think that's a big question, maybe a big unknown to some. We tried a lot of different drugs over the last year and a half. That's why this is such a long list. But the data I'm going to show you in this outcome study that was just submitted to BioRx a day or two ago was that we've really relied on Maraviroc, which is a CCR5 antagonist, and Prevestatin, which of course is a cholesterol-lowering drug. And what came out of our first paper in Frontiers in Immunology was the fact that long COVID, underlying long COVID, was the fact that they had vascular inflammation. The vascular inflammation set up a site for platelet deposition, platelet activation, inflammatory cells to come in, all clotting factors to be activated. And it was the setup for what we're hearing now more about micro clots, but something we recognized a year and a half ago when we started to see these elevations in this marker called SCD40 ligand, which is produced by activated platelets. CCR5 is activated by platelets, and that brings in other immune cells, and you get this cascade of inflammation that leads to microclots, and we think a lot of the symptoms that we see in COVID long haulers. And one more commentary. The fact is, if you go into the coronary artery disease and atherosclerosis literature, what I'm going to talk about and in terms of the mechanisms is all over the place. And I think that's been a great supporting evidence for why we treat in the way that we treat. So what we did is we wanted to see what are the outcomes of our treatments with CCR5 antagonists and statins. And so we looked at 5 symptom scores that are used routinely in clinical studies. Some of them are recommended by the FDA, really setting us up for some upcoming randomized clinical control trials. But what was so reassuring about the statistical analyses of these was our ability to correlate symptom response with biomarker improvement, because we've known all along how to target each of the biomarkers. We know, for instance, Maraviroc lowers CCL5, TNF-alpha, VEGF, soluble CD40 ligand, interleukin-6. Okay, so we've come up with a scheme to target these individual cytokines. So here's the Rankin score, which is a measure of neurologic disability. After 6 to 12 weeks, the patients responded with a highly statistical significance, and that response was related to decreases in soluble CD ligand and VEGF, 2 markers that are highly involved in vascular inflammation. Next, we have the Compass 31, which is a dysautonomia scale. Again, highly correlated with soluble CD40 ligand, VEGF, and CSF. I get that confused with chronic fatigue. But anyway, highly statistically significant decrease in symptom scores correlated with decreases in particular cytokines, so that we know going forward in a patient who has dysautonomia, what are the targets that we're looking for with drugs to bring down that will improve their dysautonomia at the end of the day. Because really, at the end of the day, it's about improving their symptoms. It's not about improving biomarkers. But our biomarkers, as we're showing here, this is a great validation of the biomarkers and how they relate to symptoms. Shortness of breath or dyspnea scale, again, statistically significant decrease after 6 to 12 weeks of therapy, correlating with GM-CSF, interleukin-2, TNF, and soluble CD40 ligand. I think this is the most compelling scale that I've seen, because the one factor that's shared between COVID long haulers, ME/CFS, fibromyalgia, post-vaccination long haulers, is fatigue and post-exertional fatigue. And to see this data and look at something like TNF alpha with a very strong correlation coefficient and a p-value at 10 to the minus 5, we've thought all along that IL-2 was particularly involved in fatigue. When we relieved the elevated IL-2, which is part of the long hauler index, the fatigue tended to go away. But to see that TNF was such a strong driver of fatigue was incredible, because we see so many patients with elevated TNF alpha as a function of being produced by pro-inflammatory macrophages, for instance, and pro-inflammatory monocytes for that matter. And again, cardiac function, again, statistically significant, related to GM-CSF and interleukin-8. So this is the first place where interleukin-8 pops up. And of course, interleukin-8 was a factor that's coming out in our new paper on post-vaccination long haulers as being one of the major statistically significant cytokines that is elevated. So the next question, or the question for us, was really, what's causing all of this? And when we started searching for causes, of course, being a virologist for close to 25 years now, and having found HIV in monocyte subpopulations, and then in 2009, hepatitis C in monocyte subpopulations, it was a natural to go look for what I think is essentially a very prominent cell type for phagocytizing and different dying cells, proteins, nucleic acids, etc. And indeed, that's where we found, and we published this in Frontiers in Immunology earlier last month, the presence of S1 protein in monocytes. And then what we did is we sorted these cells, we did proteomics on them, and confirmed what we had found by flow cytometry. But in addition, what we did is we took the same sorted cells, purified the RNA, because the question has always lingered, is this antigen persistence, or is there still virus after 15 months? And indeed, what we found in these patients who ranged from 6 months to 15 months post-infection was that we could find the S1 protein, and when we sequenced the RNA, we did indeed find RNA, so we don't disagree with that, but it was fragmented. And because it was fragmented, we really feel that there was no ability to be replication competent. And, I think other studies have shown persistence in autopsies, but the fact is they're using immunohistochemistry, which detects protein. They're using PCR, which detects small segments of RNA. They're using in situ hybridization that detects small segments. They're not really doing the whole genome sequencing that we did in these cells to show whether or not there's a replication competent virus. And now we're working on tissue to actually take a look at that. Okay, next slide. So again, this was the confirmation. I won't belabor this anymore. The confirmation by mass spec, both in COVID long haulers, and then this is coming out in our new paper, post-vaccination S1 protein in the same CD16 monocytes in post-vaccination patients with long hauler symptoms after 3 months. And what does this mean from a mechanistic standpoint? Well, these non-classical monocytes express high levels of the fractalkine receptor and bind to fractalkine on the endothelial cells and initiate this inflammation because they're carrying the S1 protein. What was very interesting to us was this paper from 2013 where that inflammation of the endothelial cells resulted in type 1 cytokines. Well, IL-2 and interferon gamma, which are type 1 cytokines, are the numerator of the long hauler index. So that was very reassuring that we were, with the aid of our computers, headed in the right direction mechanistically. The other thing is that the fractalkine receptor and binding of non-classical monocytes results in angiogenesis through VEGF, which of course we see in all 4 of these conditions, and vasodilatation. Why is that so important? Well, vasodilatation results in this head fullness that I would say 80 to 90% of long haulers talk about. It causes headaches and migraines. We think it causes brain fog, tinnitus. It also causes, obviously, vasodilatation, hot, cold insensitivity, low blood pressure, which results in compensatory heart rate increases. So you can account for a lot of the symptoms in COVID long haulers and in now post-vaccination long haulers just by what this interaction does on the endothelial walls. We call it in the new paper, of course, endotheliitis. And of course, we intervene by using CCR5 antagonists, which prevent the accumulation of these non-classical monocytes, and statins, which downregulate the expression of fractalkine. Now, why is that important? One of the major questions that's asked of us is, well, why do these cells stay around for so long? You know, they normally have a lifespan of a week. Well, the answer is fractalkine causes a senescence program that these cells no longer undergo apoptosis. So the high levels of fractalkine, which we bring down with statins, allows the apoptosis pathway to come back on. It's discussed in our 2 new papers, and allows these cells to die. And allowing these cells to die is exactly what we want to see. When we look at serial sampling of some individuals with the S1 assay, which should be out shortly, we do see that correlating with symptom improvement as well as what I showed previously. Yep. And these are my last couple of slides. Obviously, these are very involved diseases, and what we've done is we've developed a watch that allows you to track your symptoms, as you can see here, both your O2, blood pressure, heart rate, etc. But most importantly, because of the scales that I just showed you, the symptom scales, is that we've been able to program into the app the ability to basically answer the questions that's in the symptom scales and look at symptom improvements and improvements of dysautonomia scales and those other scales I showed previously on a day-to-day basis and basically log your symptoms, so that now that we showed the response to therapy and we know that it's related to these symptom scores, we wanted to be able to bring to patients and individuals the ability to monitor that on themselves. So anyway, with that, I'd like to first thank Dr. Kaplan, Dr. Belanti, and Dr. Katz for arranging this meeting, but also for some very, very enlightening discussion beforehand. I hope now that the conference is over and that's past them in terms of everything that goes into it, we can resume those meetings. And of course, the team at IncelDX, the team at the Chronic COVID Treatment Center, all of our telemedicine physicians, and a special shout out to my colleagues at the University of Costa Rica, who are absolute bioinformatics, machine learning, AI experts that have done all the fine statistics in these numerous studies. So thank you very much, and I'm happy to answer any questions.
Okay, so that was kind of lighthearted. So you've just redefined the entire field. We're running shy. I'm going to reduce it to one or two questions. The good news is we've got you for another whole presentation, and we have you for a panel. So there'll be lots of opportunities to ask questions. Clearly, what we're talking about here is revolutionary. We're talking about revolutionary in terms of not just new biomarkers and a new way of thinking about these diseases, but of treatments, and treatments that look like they are working. So we've got a lot to go, but much is already happening. I do want to ask you one question, since I get the prerogative of moderator, and it will be an ongoing conversation we have. And by the way, the conference isn't over yet. Friday afternoon, the conference is over. But EBV, reactivation of EBV. What are you looking for markers that tell you that that's what's happening?
Yeah, you know what? Kaplan, that's such a great question, and one I wrote a paper when we were at Stanford on EBV and what really are we looking for and why. And you know what? I'll tell you, and we're going to develop it at InCellDX. I developed an assay that did RNA to DNA ratios with these DNA viruses, and I did it for CMV. And I think we're going to do it now for maybe the full panel of herpes viruses, because I think that is such a difficult question. The serology is confounding, especially when people talk about IgM in the chronic herpes virus family. They're just so inconsistent. But if you use the DNA of a DNA virus as the denominator and then look at RNA expression, you would be able to have a ratio that would truly inform you whether or not you had reactivation. And I think, you know, with all this going on in COVID and maybe for a long time to come, something like that is truly necessary in the field.
Great. Let's go to some of the questions we have. One of the questions is, do we know the percentage of vaccinated individuals who may get long-haul COVID symptoms?
Well, you know, it's hard for us because we just have people enrolling on a continuous basis to say prevalences, for instance, or in any kind of rate. So we don't know how many of our COVID long haulers have been previously vaccinated. We know that they have. We know that you know, we don't know the prevalence of post-vaccination long haulers, and we see, you know, I think we have 1,200 or 1,500 enrolled, but we don't know how that equates to a prevalence, which is probably still pretty low in the population. So it's really hard the way we're set up to figure out prevalences like that.
Are you worried about statins causing mitochondrial dysfunction in the long-haul COVID patients?
So here's the thing, with all of our treatments, they're for such a short period of time. These are not lifelong. Most people on statins are on statins, you know, years and years and years and years. The patients who are on Maraviroc, there's a great 5-year study of the safety of Maraviroc in adult patients, for taking it every day for 5 years. We're giving it for 6 to 12 weeks. Some maybe a little bit longer, some a little bit less. And Maraviroc has been shown to be safe in the pediatric population. It's the only CCR5 antagonist safe in the pediatric population. And now with Delta, we're seeing many pediatric long haulers, and with Omicron infecting everybody and their brother, we're expecting a huge surge once again in pediatrics as well as all ages.
Okay, one more question, and it's kind of the obvious. How long does it take to get results from your assay? Can any family doctor order it? Have you found patients that need to be on more than one medication? How do patients do when they stop medications? That's a little bit of a long conversation, but if you can condense it.
But it's it gets to the heart of the matter. The fact is, because we're treating the cause and we're not treating symptoms, these other long COVID programs around the country, what I find them doing is they're going to a neurologist, they're getting treated for dysautonomia. They're going to cardiologists and getting treated for POTS. They're going to a pulmonologist to get treated for shortness of breath. And some of those therapies are working for that particular symptom. From day one, we said we're going to treat the cause so that when we're done with therapy, we're going to get long-term response. And we're seeing that. I mean, other than our patients now coming back that we haven't heard from in 6 months getting Omicron, we are seeing long-term response to our therapies. And yes, sometimes we use other drugs, but our goal is restore the immune system back to normal with Maraviroc and statins. Once it's back to normal, we may start treating symptomatically at that point. And the S1 assay is important because we can say, okay, we've taken away the inciting event, and now we can just focus on your symptoms. Start increasing activity. If they tolerate it, we get them off therapy. But response to exercise, a good response to exercise is the key milestone for all 4 of these conditions that I spoke to. We know when a patient is getting better when they can then exercise a little bit and they're not laid up for a couple of days. And I had one patient who called me and said, you know what, Dr. Patterson, I just can't get past, I can only work out with weights 3 times a week, and I used to do it 6 times a week. And I said, you know what? God bless you for doing it 3 times a week, number one. And you know what? It'll come. Conditioning doesn't happen overnight. So anyway, it's a good story.
Thank you for a truly outstanding, spectacular presentation. Thank you for truly outstanding work. We look forward.
Like to make a remark.
All right, Dr. Belanti would also like to make a remark as he comes in here. We look forward to further conversations during this conference with you. And now I'll turn it over to Dr. Belanti.
Thank you.
Dr. Patterson, I wanted to congratulate you on an absolutely astounding, outstanding contribution. I have long spoken about persistence of antigen as a driving force in immunologically mediated diseases. Your data supports it specifically and beautifully. I wanted to just make one remark. Mention IL-8. I think the audience needs to know that one is not really an interleukin. It is actually one of your chemokines, but it still retains the IL-8 designation. So that fits in line with your emphasis on chemokines. The last point is a paper that was just published in Cell with a list of outstanding authors who spoke about the post-acute sequelae of COVID-19. If you haven't seen the paper, I will send it to you, but it's a preprint. And in it, they evaluated 309 COVID-19 patients from initial diagnosis to convalescence 2 to 3 months later, and they integrated clinical data, patient-reported symptoms, and they resolved 4 PASC anticipating risk factors. And they found 4 clinical entities of significance: type 2 diabetes, SARS-CoV-2 RNA-emia, Epstein-Barr virus viremia, which Dr. Kaplan referred to, and specific autoantibodies. I think that your findings are extremely important, and we will cover this more, I think, in the roundtable in the Friday session. So thank you again for an outstanding contribution.
Thank you. I appreciate the opportunity to all of you, and what a great conference, and I look forward to Friday.